Hello, my name is Benjamin Farrell, and I'm the coordinator of global programs here at IASP. This podcast is an installment in our Global Year series on translating pain knowledge into practice. Today, we will be hearing from Dr. Romy Parker and Dr. Saurab Sharma as they discuss the barriers, challenges, and opportunities of translating research into practice in low-income settings. Professor Romy Parker is the director of the Pain Management Unit at the University of Cape Town in South Africa. Romy is an active researcher. Her research focuses on pain with emphasis on developing and testing mechanism-based treatments relevant to the South African context. Romy has extensive clinical and research experience and has contributed to several national and international initiatives to help improve pain management, especially in low-resource settings. Romy has served as the chair for Pain, Mind, and Movement SIG at IASP, and she is also a council member there. Dr. Saurab Sharma is a postdoctoral research fellow at New RA. His postdoctoral fellowship is partly supported by the International Association for the Study of Pain, John J. Benica Fellowship. His PhD focused on improving pain research, assessment, and management in Nepal, which was rated as a thesis of exceptional quality. Prior to commencing his PhD in 2017, Saurab worked as a musculoskeletal physiotherapist and lecturer in Nepal for a decade. He is one of the commissioners of the Lancet Commission of Osteoarthritis, and he is also a founding member of the Global Alliance of Pain Patient Advocates and an active member of the Pain, Mind, and Movement Special Interest Group of IASP. With that, I'm very excited to hand it over to Saurab.
Thank you. Thank you, Ben, so much for a lovely introduction. And welcome, Romy, to this IASP Global Year podcast. We are very excited to have you and learn a lot from you and from your experience.
Thank you for inviting me. It's lovely to be talking to you, Saurab. It's been a while since we've had a good conversation, so I'm looking forward to having a good chat.
Yeah, and me too. While asking questions, I'll do two things, Romy, if you don't mind. So I'll ask a few questions about yourself, your personal life and professional life, just to know you better. And then I'll dive into some of the topics for today, talking about translating research into practice in low-resourced countries.
That sounds great. Am I allowed to be a difficult guest and ask you some questions too? Because you've also got a wealth of experience from working in low resource settings. And I think this is an interesting conversation for us to have, to be learning from each other's experiences. So can I ask a couple of questions too along the way?
Yeah, sure, Romy. Please shoot. And yeah, please don't ask difficult questions. Yeah. So, Romy, could you please describe your career to our listeners so that we can learn a little more about you and your amazing journey so far?
Sure. Thanks, Saurab. That's a tricky question to ask someone of my age because you could spend a long time just hearing about my career. But my basic qualification is as a physiotherapist. And I think like many physiotherapists, I just wanted to do sport. And I did. I did an honors in sports science, and the big sport in South Africa is rugby. So I spent some years on the side of the rugby field running on like the hero to rescue the injured players. And I enjoyed that. I also got to the point where I got a bit frustrated with athletes who don't really do what you advise them to do. So I took a bit of a detour and I started working in the field of rheumatology, which as an undergraduate, I never imagined that I would work in the area of rheumatology. But rheumatology really opened my eyes because I had the amazing privilege of working with some incredible people who, in rheumatological terms, had severe disease, whose joints were destroyed, and yet they were still living fulfilling, challenging, rewarding lives and weren't disabled by pain and weren't constantly suffering from pain and asking for help with pain. They would come to me and say, oh, I'm having a bit of a flare up. My joints are a bit swollen. Can you help me get on top of this? Because the sheep are lambing and I need to be working and getting out into the fields with my sheep. And they were just amazingly resilient people who weren't suffering from pain, despite the fact that they had severe damage. And then I had this other group of patients who also had rheumatoid disease, whose disease was relatively mild, and yet they were completely disabled by pain. Their lives were falling apart. And so that's when my questions started in terms of what is pain, because I had this very clear evidence in front of me that pain and severity of disease or tissue damage weren't directly correlated to each other. So what was going on here? So that's when I decided to study some more, and I did my master's in pain in the UK, and then I came back to South Africa. And when I came back to South Africa, I shifted out of the rheumatological realm into HIV and AIDS. At that time, we were in the middle of a terrible AIDS epidemic in South Africa. We did not have easy access to antiretrovirals. And we were becoming more and more aware that pain and widespread pain was a very, very common symptom in people living with HIV. So in my PhD, I looked at the prevalence and characteristics of pain in people with HIV, and then looked at whether a non-pharmacological intervention similar to what we would use for other chronic pain conditions would be effective. And surprise, surprise, what did we find? That pain in people living with HIV is incredibly common, but doesn't have a direct relationship to disease severity. It wasn't related to CD4 counts. It wasn't related to viral loads. It wasn't directly related to comorbidities. So it was a problem in and of itself. And that when we ran a non-pharmacological intervention, which included education and self-management skills and exercise and mindfulness and relaxation techniques, our patients did amazingly well. So that really brought me to the point of recognizing that as a physiotherapist, I have a fundamental role to play in contributing to pain management. And that's embedded me in my position here at the University of Cape Town. I started at the University of Cape Town as a physiotherapy lecturer, and I'm now just about pain. So while I teach the physios, I also teach the occupational therapists and the medical students, and we're involved cross-disciplinary pain teaching. So yeah, that's a bit of background about me and my work.
That's an incredible journey, Romy. So inspiring. When you said that your athletes weren't compliant and you wanted to change, I thought that you're going to say that you went to teach so that students would be compliant and obedient.
Well, now I'm sure you understand this because the conversation I've had with my students last week, I do cringe a bit at my attitude back then about my athletes not being compliant, because now I've shifted to a much more patient-centered approach and think about adherence rather than compliance. And what did I know to be telling them what to do? I should have been aligning with them and engaging in that way. But I got there eventually. It was just a long journey of enlightenment.
Yeah, exactly. Patient-centered care is such an important thing, and listening to patient and clients is very important. Thank you, Romy, for sharing your story. So I know that you're very busy. I always think twice before writing an email and asking for favor. But whenever I do, you're always kind and generous, and you respond back and agree to everything. So you've been teaching, supervising many students and researching, and also doing clinical practice. And apart from other roles like reviewing and journal editing and all of that, and also contributing to countless number of committees. So how do you find time and how do you balance work and life?
I have no idea would be the honest answer, but then I get down to the practicalities, which I guess is some of the self-management skills that we work with patients, right? In terms of scheduling and prioritizing and thinking about what's important. So my work is important to me. It's something that I value. And a few years ago, I was really lucky at the World Congress on Pain in Boston to be invited to participate in some workshops and to think about your own mission and vision and your approach to things. And I recognize that my personal mission in South Africa is that I really believe that every South African should have access to a healthcare professional who understands pain. And so my goal is to make a difference in people's lives by engaging with healthcare professionals and helping people understand pain. And I think that's different to knowing pain. There's a difference between knowledge and in-depth understanding and really grappling with pain and what it is and how we can make a difference in people's lives. But if that's my philosophy, then I also have to understand myself. If that's my mission, that I'm going to help people understand, then that takes understanding of yourself, and that means that I have to look after myself as well. And so I keep an eye on the ball. I work hard and I play hard. So when I'm working, I'm working. I do not work in my bedroom. I do not work in my lounge. I have an office at home, and when I'm working, I work in my office at home, or I come here to Groote Schuur Hospital and I work. And when I play, I'm out on the mountain running with my dogs, or I'm surf skiing on the sea, or I'm paddling on a river. And all of those activities that I do are very mindful activities. If I'm not present when I'm running on the mountain, I'll be flat on my face. And if I'm not present and conscious on the sea, I'll be swimming instead of paddling on it. So I really try and adopt that mindful attitude of being present in what I'm doing at the time, so that I am committed to what I'm doing at the time. But that also means that when I'm not working, I'm really not working.
Yeah, that's so important, isn't it? Work and life balance and keeping them separate, and yeah, enjoying both separately, not together. That's very important. Thank you, Romy. Just very briefly, how does your day and week look like?
It's Saurab, there is no typical day. You should know this as an academic. I always laugh at people saying, you should structure your day. You want to do your reading and writing at the beginning of the day. But sometimes my patients need to see me at 7 a.m. because that's the time that they can get to see me before work. Maybe that's why I love my job, because no 2 days are the same, but all my days include patients contact. I still work with patients either one-on-one, or I facilitate pain management groups that we run. I even have some patients in a hydrotherapy pool. So I get to do some traditional fun physiotherapy. Every day has some teaching. Engaging with patients is teaching, but also engaging with students and colleagues, undergraduates and postgraduates. Teaching is fundamental to what I do. And I think is one of the things that gives me the most joy when I'm engaging with someone and I see them really grappling with the topic and then saying, do you mean... hold on, I think I've got it. That's just the best moment. And then every day has some research. I'm incredibly lucky here that we've built a team of pain researchers who are really committed to engaging in meaningful pain research and looking at novel and sustainable ways of treating pain that are appropriate for our setting and our environment. And so research is there. And then the other side, the leadership side, the management side, every day has a bit of meetings or outreach or policy engagement or scratching my head about how I am going to get the Minister of Health to take this seriously. So every day has those different components. The recipe is slightly different each day. That's just the way it goes.
Yeah, and that keeps work and life very interesting and exciting. Yeah.
Yeah, totally.
Yeah, I was going to ask you what your favorite pastime is outside of work. So you talked about running and a lot of other exciting things. So you seem like a really fun and outdoor kind of person. Is that right?
Yeah, outdoor life is an important thing for me. So something that you probably don't know about me was that I was born in Rio de Janeiro, Brazil, and we lived there for 10 years before moving to South Africa. And my parents delight in telling the story that they took me camping when I was 6 weeks old. And that was the first time I went camping on a beach in Brazil. And so the outdoors is just something that's always been an important part of my life. And I still enjoy going to the bush and going camping. And in South Africa, we're so lucky because we have game reserves and we pitch our tents mostly inside a fence, occasionally outside the fence, which might mean that you don't sleep so well when you're outside the fence. But yeah, you have these amazing opportunities. And for me, it's good for the soul. It reminds us about our place in the world and who we are. Don't you think?
Yeah, there's such lovely nature outside, and South Africa is beautiful. I've been there once, and yep, should make use of all the natural resources you have. So now let's dive into the topic for today, translating evidence into practice in low-resourced countries. So could you please describe what pain research currently looks like in South Africa?
You're supposed to ask me easy questions. So where is pain research in South Africa? When you learn research methods, you get taught this idea that first we should do the epidemiological research, and then we should do the mechanism research, and then we'll design the interventions. But when you're living in a country of 52 million people and you have data that 1 in 5 of them is living with chronic pain, I'm not going to wait around to follow that line and let people suffer while we explore things. So we're doing it all at the same time. So we are doing large epidemiological research. So my colleague Peter Kammerman and his team up at Wits University published a paper in Pain, I think it was in 2020 now, based on the South African household survey, so a large population-based survey identifying that 1 in 5 South Africans are living with chronic pain. We're now working on that data set further to explore high-impact chronic pain, because we are all familiar with the data that many people are successfully living with chronic pain. They might have pain, but they're not necessarily in our clinics. What we're particularly interested in is the high impact chronic pain. Who are the people with chronic pain who are disabled by their pain, who need our input and help? And so we're doing that epidemiological descriptive work at the moment, and also other cross-sectional studies describing the burden in South Africa. But at the same time, my colleague, Dr. Tori Madden here, who's part of our team at the University of Cape Town, you know Tori well, is leading our team and collaborating with Peter Kammerman and Tony Wadley at Wits on mechanism-based research, really looking at factors that might be making South Africans particularly vulnerable to developing chronic or complex pain. So Tori is working on a really novel experimental model to explore the psychoneuroimmune interactions in people with HIV that may be making them more vulnerable to developing chronic pain. And that links with Jill Bedwell, her PhD candidate's work, looking at the 2-hit hypothesis in South Africans of what might of your early life trauma, adverse childhood events have been. They have a relatively minor second hit as an adult, but that's enough to make you vulnerable for chronic pain. And they're exploring this mechanism-based research using lab models for secondary hyperalgesia, so particularly focusing on spinal cord mechanisms. And then sort of my group of work is really around sustainable interventions that can be rolled out at a primary healthcare level to be managing people with chronic pain. Because 52 million South Africans, only 9 or maybe 11, if we're being generous, tertiary hospitals where chronic pain management teams are available. That equation doesn't work. So we've got to be developing models to be managing chronic pain at a primary healthcare level, where people can access and get the treatment that they deserve close to home, and perhaps prevent them being disabled if we can identify them and impact early enough. So our work is looking at different models of pain education empowerment programs, education, exercise, problem solving, goal setting, mindfulness, relaxation, all of that mix, and looking at models would be effective for different patient groups. And how can we deliver that at a primary healthcare level that would be sustainable and impactful in South Africa? So that's really the range of work. And then there are always a couple of other projects that chip in. So we've got a new group looking at chronic pain in cancer survivors, and Tony Wadley's work's still looking at different profiles of chronic pain in people with HIV.
Perfect. Tons of amazing work and a lot still ongoing. So very excited to learn about everything that you're doing, and we'll look forward to reading more of your papers and your colleagues in the near future, Romy. Very well done. So you have some research already and a lot of work is ongoing. So in order to inform your clinical practice, your and everybody else's in South Africa, do you think you have enough local research to inform your clinical practice? The reason I'm asking is for myself to think, how is your practice informed? Is it via local research, or how do you keep that in equation?
Yeah, this is always a challenge for us, isn't it? And I'm sure you've engaged with it a lot, of taking the evidence from a developed country and then really grappling with it and thinking about, how does it apply in my context, with my population, with my resources? How do we apply this? Is it even going to be effective in my population? I think, firstly, the research that we've done here on different models of interventions is encouraging. All right, so certainly shows that the principles developed and modeled in other countries, developed countries, can be applied here, but they have to be modified. They have to be contextualized. They have to be culturally contextualized. They have to be resource contextualized. You can't just transplant it from one to the other. So the initial work that we did here was about adapting evidence from elsewhere and testing to make sure that it was appropriate here. And as we've done that, we're now identifying the challenges of, where do we need to do specific research on our population because we think our population is different? Or where do we need to do specific research because we need to come up with a solution that is specific for our population because our challenges and our environments are different? So is there sufficient research to inform clinical practice for pain care in South Africa? Yes, but the healthcare professionals need to be empowered and have the insight of how to adapt that evidence to make it relevant for their population. And I want to ask you that question because the evidence says we should be approaching a problem in this way. But if we look at the context or the culture, as a clinician, I have to think that through and think about how I'm going to deliver it.
That's a good question, Romy, especially for Nepal. And as I've visited Cape Town, which I thought was a high income, really sophisticated place, and our context is quite different, very rural part of South Africa for most majority of Nepal. So most research that is derived from high income countries, I think may not apply, especially due to language barrier and context and other environmental and resources, as you highlighted. Very basic things that we read in our physiotherapy textbook and what we are taught. Hydrotherapy was a treatment for almost all the problems, and it looked like a magical solution. And we are landlocked country, so no water or no sea. So that's out of the question. And so no swimming pools and no whirlpool and other sophisticated hydrotherapy. So I always wondered, how do I teach or prescribe hydrotherapy for my patients? And the other thing that was quite interesting when we read was walk on a beach and walk on sand. We don't have any sand in Kathmandu and all other simple basic things. So these were for exercises and other things that we learned about pain management and other rehab. So all the psychological therapies, we don't have many psychologists in Nepal, especially in the area of pain. So we don't really know whether psychological treatments work in Nepal and whether or not patient would find it acceptable as a pain management technique. And even education. So education is the cornerstone for most of disease, and our patients aren't really very used to getting education in the form of treatment. So that was another thing. And everything that we read were in English and developed for high income countries and for Western cultures. And most of them didn't apply well for our local patients and people from very diverse cultures. So all of that I had questioned, but I had trusted, but again questioned how to use that in practice. So it was quite hard. So I think my research is derived from my own clinical practice and whatever you said earlier. So I found it really challenging, and some of the things that we have done, not a lot deal as you have. But in terms of education, we adapted patient education and pain education for use in Nepal for people with low literacy levels. And we found that people thought that pain education or education as a treatment in itself, a credible treatment and acceptable treatment, and they really enjoyed. But the level of education that we pitched was very basic. So it was more of covering the themes than talking about complicated neurophysiological aspects of pain. And we try to use a lot more metaphors and stories so that they can relate. For the trial that I did less talking and let patients speak and their family members speak so that they learn from their own experiences. And I help them reflect. But again, that kind of approach is generally not the usual practice in Nepal, because clinicians generally do all the talking and patient has to listen and then go back and try to
Yes,
understand
I'm
what
here
the
to
clinician
tell
said.
you.
Yeah. Yeah,
Yeah.
so there are tons of things to do still, and it's really hard, but I think we'll get there together, of course.
I think that's the key thing that you've just identified, is that we'll get there together. So, I think in terms of translating the evidence into practice in low resource settings means that we as healthcare professionals have to be really sophisticated in our problem solving and our thinking about what it is that we need to be offering our patients. So the literature might say education is important, and that these key concepts are important for somebody with chronic pain to learn. But if I'm working with a grandmother who is unable to read and write, then as a clinician, I need to think about, so how do I get these concepts across? I need to know her culture. I need to know her environment. If I'm treating her on a home visit, I need to be able to sit down at her home and draw in the sand about pain for her to understand. So I don't think the challenge is in the evidence. The challenge is for us as clinicians to translate that. If the literature is saying, as you were saying, that walking on the beach in the sand is really good, the question for me as a physiotherapist is why? Is it because of the proprioceptive challenge? Is it because of the mindful component of walking in that environment? Can I break it down and then think about, well, if I'm in the mountains of Nepal, how can I take those principles and apply them for the person in front of me? I have colleagues who work up on the border of Mozambique in a town called Manguzi, and they don't have swimming pools. It's a very poor rural environment, but they have the most incredible lagoon. They do a hydrotherapy class twice a week with the community women. They go and meet at the lagoon. They stand in the water and they do their exercises. They've engaged with the principles of what is it about hydrotherapy? Is it the non-weight bearing? Is it the fun? Is it the group aspect? What are the components of this treatment? And then how do I make it work in my environment? And I think that's really the challenge, is not so much us needing the evidence, although we need the evidence that it works in our environment, but for the individual clinician, the challenge is, what's the underlying components of this treatment and how do I adapt it for my patients and my environment? And that's really fun, I think.
Yeah, that's super, super important. And most students or clinicians in developing countries like ours don't have that skill. I wouldn't say most, but we aren't generally taught in our schools the clinical reasoning aspect of our practice. We are generally taught, I cannot generalize, but when I went to school in India, we weren't taught any of the clinical reasoning aspect. We are taught facts. So you do this, you don't do this. There are indications for these and contraindications, and you can do this and don't do these many things. And we are never taught why to do it and how to do it and how to modify. And if there are any obvious kind of contraindications. Yeah, clinical reasoning was a big gap in our education when I went to school. So I tried to overcome that and got the Mark Jones book on clinical reasoning and started reading. And then that was my favorite topic to teach back in Nepal. Yeah, there are certainly a lot of gap in terms of evidence, and again, utilizing the evidence back in our practice by using some of the reasoning process, which is also, I think, a challenge, at least in our country, because physiotherapy education itself is quite new. It's only 12 years old in bachelor's degree, so quite young. And we don't have psychology degree, especially focusing around pain. We do have psychology, but very few seats, but we don't have a focus around pain. They're only starting to have interest around pain and resilience. And I keep getting requests to use outcome measures that were adapted into Nepali by a master's in psychology student at 2 different universities. And I feel really happy and proud. Yeah, so it's getting there, and eventually we'll get there. And as I said earlier, together. So thank you, Romy, for the insight and the need for a clinical reasoning. Of now I know how much I miss teaching, and I've only been doing research for the past few years. Teaching is fun. I was going to ask about barriers and challenges. We did touch about some of the barriers and challenges in translating research knowledge into our clinical practice, especially in the low resource setting and context. Can you think of any additional barriers and challenges you can think of?
Plenty. So I'm just thinking about young physiotherapy graduates I'm mentoring at the moment, and spoke to her at the end of last week, and she was exhausted. She's on an outpatient rotation, and she had seen 30 patients that day in the outpatient clinic, and that was normal. That's what was expected of her. And she is meant to assess and diagnose and treat and fix them and send them on their way. And she is at that clinic. It's a rural clinic, once a month. So the chances are that she is not going to see that patient again. Many of them walk 10 kilometers just to get to the clinic, and you get one chance to see them. So the barriers and challenges are often those system barriers and challenges of, how do I really make a difference when I just feel completely overwhelmed? How do I give my patients the kind of care that they deserve and that I was trained that I'm meant to deliver, when in reality I've got maybe 10 minutes? Oh, and they don't speak the same language that I do. So they speak Zulu and I speak English and Afrikaans, and they might speak a little bit of one of those languages, and I feel completely inadequate because I can't engage with them. And there is meant to be a translator around, but they're also trying to work in 3 different places at the same time, and those sort of challenges. And I was taught to give patients exercises with TheraBands, and we haven't had TheraBand in stock for 9 months because there is no budget. And it would be great to give this lady a crutch, but there are none. Overcoming those system challenges is difficult. You talked about teaching people clinical reasoning, but it's also problem solving out the box. You can actually adapt an umbrella into a walking stick really, really well. And in that culture, everyone has an umbrella. So let's look at umbrellas as walking sticks and crutches. Everybody has bicycles, and there are old rubber tires everywhere. Can we cut up those strips of rubber to make your own TheraBands and different ways of exercising? When you're out and about, if you see tin cans on the road, can you start collecting them up and fill them up with sand to make exercise things? And really just helping people be innovative in overcoming those kind of challenges. Because one of the biggest challenges that I have sitting at the academic center in Cape Town is being contacted by rehab professionals, physios and OTs out in our rural areas who are facing those sort of challenges. And they're saying to me, but you don't understand how difficult it is here. We don't have all that fancy equipment that you have. And then they get blocked. And so my role in mentoring them is to say, okay, well, how do we problem solve around that? And then I translate that to, so you've now learned to problem solve and be innovative in the way that you're practicing as a physio and OT. Can you help your patients learn to problem solve and be innovative about their daily challenges as well? So taking their own lessons into their clinical practice and how they work in a patient-centered way of engaging with their patients. So the barriers and challenges are huge. And I think one of the things that gets us in low and middle income countries is that it's easy to throw your hands up and say, oh, but we just don't have the money. And that is a barrier and that is a challenge, but it's also a massive opportunity because that doesn't have to cost lots. Actually, we can do really, really effective treatment without it being incredibly expensive. We're smarter than that. We can come up with the solutions. And I honestly believe that those of us working in these environments can show the rest of the world how it can be done.
Yeah, Romy, that's a fantastic message. And I think that could be the key one-liner statement out of the entire podcast. That's really insightful, Romy. And everything that you said earlier were quite resonating with me. And I literally had goosebumps when you're talking about the rural settings and the number of people who come to rural clinics. And that just gave me all good flashbacks and trying to problem solve in rural Nepal. Fantastic. Or maybe I'll just share one tiny experience. As a young physio, I just graduated maybe 2 years after physiotherapy school, and I went to the mountains, so area of Mount Everest in that region for a health camp, for a 3-day health camp. And I tried to think of all the possible ways to adapt exercises and adapt education to teach and make it simple because it's a different place and different culture. And As you said, I would have consultation for 5 or 10 minutes maximum for a patient. So that's what I thought when I went there. But the very first day, there were 500 people lined up for their consultation, and they had walked 2 or 3 days to get there. And the type of patients that came to the clinic were quite different than what I would see in the hospital I was working at. They had more disability and extreme deformities, and they hadn't seen a clinician or a doctor or a health professional ever. So it was a completely different situation, and my initial anticipation of problem solving did not work. And I had to line up patients and make a really big group of circle, and I had to give group kind of education, general kind of education on how to manage pain and how to cope with pain in more evidence-based manner, and generally reassurance around pain. And that really directed the research that I did for my PhD as well. That is developing resources to educate around pain in a way that it is a single session, so that people don't have to come back again, and also make it very simple and understandable so that people with no education at all could understand, and also could be delivered via mass media or TV or radio or any other sources, so that it's cheap and accessible to all the places. So yeah, it did touch all of my memories, and thanks for bringing those memories, which was quite pleasant, and I really enjoyed doing all of those work back then. Now let's move back into the question. So we touched several barriers. So are there any other extra ones that you think are barriers for translating evidence into practice?
Maybe I touched on it implicitly when I was answering previously, but I think one of the biggest barriers that we face, those of us in low and middle income countries, is ourselves. We're not second best. We're not the poor relatives. We know our population and we know our work, and we can make a difference. And sometimes when somebody contacts me and they say, oh, but you don't know how bad it is here, I say, we do know how bad it is here. When I hear your story, we know how bad it is here, but we can make a difference. So sometimes we are the barrier as healthcare professionals, with this idea that it's so bad here that we can't make a difference, and we can turn that around into an opportunity.
Yeah, exactly. It's all about mindset, isn't it?
Yeah.
And you also did touch about some of the opportunities and how we may overcome some of these barriers. Do you have any other things to add on the list you have already touched upon?
Yeah, the one I wanted to share with you was a lesson that we learned way back in one of my PhD studies, that one of our key opportunities are our patients. One of our amazing resources is our patients. So in my pain and HIV work, we ran a positive living program, which was a 6-week exercise and education program for people with HIV and chronic pain. And the control group were given the workbook, the educational material, whereas the experimental group were given the educational material and then attended the clinic once a week. It was a peer-led group. They had education and exercise and relaxation and goal setting and peer support. And the patients in the experimental group did wonderfully well. Their pain got better, and that effect lasted for several months. And then we looked at the control group results, and as a PhD student, this made me want to sit down and cry, because they got better too. So I was like, no, that's not supposed to happen. They're not meant to get better too. Before starting the study, they had all been observed for 18 months, and none of them had got better during the waiting list time, but everybody got better. What happened? So we interviewed the women in the different groups. These were all women, and the women in the control group were just incredible. Normally in studies, when we give people educational material, when you just give somebody a pamphlet, I don't know about you, but if someone gives me a pamphlet, it tends to end up in the dustbin or lost at the bottom of my handbag and kind of crumpled up, and I don't read it. And we know that most patients, when you give them a printed pamphlet, don't really engage with it. These women, not only did they get the workbooks that we gave them and engage with them, they invited their friends round for a coffee club once a week, and they worked through it together. They set up their own groups. They did the exercises that were described in the workbook together. They set the goals. They did it. They were so thirsty for knowledge and understanding of what was wrong with them and how to manage themselves, that they just grabbed every little bit of information that we gave them and they ran with it. So our patients are an incredible group of people. They are resilient and thirsty and keen. And I think they are a massive opportunity that if we engage with and partner with people in pain, they're the ones who'll create the opportunities for us. And they're the ones who can really take leadership in a lot of this work where there aren't enough of us to go around. In our settings, there aren't enough of us, but the peer leader, the expert patient, they are an incredible resource. I mean, they're just, for me, the most incredible group of people because they just grab stuff and they make it happen and they make a difference with it. They're great. And I'm sure if I ask you about those experiences, there are a couple of people that you engaged with on those long clinic days when you're like, that one, if I could have got that person to come back again the next day, I know they would have started an exercise group and a this and that. Do you think they're an incredible bunch of people?
Yeah, and almost always they are women, and yeah, they are incredible. That also reminded me, I could go on and on. Maybe I'll just briefly touch on a story that I have. So there are lots of women group in Nepal, and most of the community healthcare workers are women. And it's been shown in research, not only in Nepal, but also in various parts of South Asia. So these women group are quite incredible, and they have the power to change the entire society and healthcare management of people in their community. So the example that I was going to share was from Women's Health Clinic. So these women in the Women's Health Clinic, they empower each other. So they are a group of people who support each other and they learn about preventing and managing uterine prolapse and all other women's health related problems. And so they learn about the problem, they learn about the solution, and they go back to the community and share with the rest of the community and empower their women community more broadly. So they are an amazing group of people. And yeah, wish more people were like that. And I think one difference that I find between high income countries and low income countries, especially when I read literature, is the role of family and community. Here in the West, we don't focus much around family and community, even during patient care, as much as we do back home. So family and community is a big support. And I think the biggest asset in translating research and clinical practice into the community.
Completely. It's not just we, the experts, they're the experts, and they've got resources to bring that makes a huge difference. I think that for me is one of the most exciting things, is to be really partnering with our communities and engaging with them and empowering them. So rather than us feeling like there aren't enough of us to go around, of saying, well, let's grow the pool and let's build the team beyond the traditional healthcare professional idea and into the communities, which is really empowering and uplifting for everyone.
Yeah, for sure. I've asked you so many questions, but I still have so many questions in my mind, but I think I will continue asking. So do you have any messages for people with lived experience of pain, for clinicians, for researchers, and for policymakers from other low and middle income countries or even high income countries? So any messages for any types of stakeholders who are involved with pain and pain management?
So I think messages for people with a lived experience of pain in low and middle income countries, this is probably the same message for people in high income countries, is the majority of pain does not require expensive MRI scans and PET scans and fancy surgical procedures and the most recent drug. Actually, knowledge, living a healthy, balanced lifestyle, exercise, having fun, engaging in meaningful life roles, getting up with a purpose every day makes a difference to pain and makes a difference to your health and makes a difference to life. And that our fundamental treatments are to help people shift from living pain-centered lives that suck you into that black hole to living a life. A metaphor I quite often use in our groups is that when patients come to our clinic with chronic pain, I see pain embodied. This person is pain. They and pain are one. And our goal is that they will learn to put pain into a backpack We might not be able to get rid of pain altogether, but we can put it into that backpack and they will go back to being themselves. They need to be fit enough and strong enough to carry that backpack in the same way that if I had HIV or diabetes or hypertension, I need to be fit and strong to carry my backpack, but it stays in the backpack and I am me and I can live my life and it's a meaningful and valuable and worthwhile life. And that doesn't take sophisticated scanners and fancy Western hospitals. It takes the skills that we have and that we know in our societies and in our cultures are important. That would really be my message for people with a lived experience of pain, who are living with pain every day, is that those skills, those treatments, to put pain into a backpack and to be fit enough and strong enough to carry it and still enjoy your hike are so accessible to all of us. And then for clinicians to focus on that, to focus on helping people enjoy the hike and use all the resources available to them to be fit enough and strong enough to carry the backpack and to be comfortable with the backpack. And for researchers to look at novel ways of treating pain in our settings and environments that are culturally meaningful, but that are sustainable. I think I've said this to you before, Saurab, but I always laugh when we go to World Congress and somebody goes, we've identified a new receptor, or we've identified a new molecule, like we're going to now find one drug to fix pain. But we all are comfortable with this idea that pain is a multiple, complex, supersonic, diverse thing. One thing is never going to fix it. So for researchers, I think we need to get more and more comfortable with designing and testing the multimodal treatments. And can we find another word for non-pharmacological, Saurab? I'm tired of being the not.
Yeah, we definitely need a term that's accurate and also meaningful and not non.
Non, yeah?
Yeah.
Not the problem.
Not non-surgical or
Yes.
non-pharmacological.
Non-medical, so it's just everything else. No, I want to be something healthy and engaging and meaningful. And yeah, maybe a message for clinicians is we need to be much more purposeful in prescribing these treatments for people with pain. Not it would be a good idea for you to learn more, or it would be a good idea for you to exercise, or it would be a good idea for you to practice mindfulness or to do some relaxation, but to prescribe it. Here's your treatment. I am prescribing you a course of learning, and I am prescribing you a course of exercise, and I am prescribing you a course of mindfulness, and to be much more purposeful about our approach in that way.
Yeah, and also prescribing nature walk. Do you do that?
Yeah, so the Japanese, what do they call it? There's a term in Japan that you go for a forest shower. And that catches it so nicely, right? Of like just immersing yourself in that environment. Yeah.
Yeah, beautiful. In the very beginning of our chat, you mentioned about a Ministry of Health. So do you have anything for policymakers and ministries? What can we do and how we may influence policy?
Yeah, how do we influence policy? It's something I'm grappling with at the moment. So all suggestions accepted here, because we've been giving the ministries, the Department of Health, the burden data that 1 in 5 people are living with chronic pain. But in a country like ours, where we have an HIV challenge that is ongoing, where we have an exploding type 2 diabetes epidemic, hypertension, the chronic diseases of lifestyle in our environment are really exploding. It's difficult to balance that equation, right? So the challenge now is not just to target the Department of Health, but in our environment to also talk about the burden of disability, because if somebody has pain, they're also more likely to be disabled. And if they're not working, they need a disability grant. And so social services come in. And I think that's often the challenge, is that if we want to make a difference for pain, we want to reduce disability, which means the Department of Health needs to spend money and will save money in social services and social development, which is a different department. So if we want to make a difference for policy, we can't just do it in a Ministry of Health or a Department of Health. We need family services. We have a Ministry for Women and Children. We need multiple departments to come together and recognize that this burden is about more than pain. It's about suffering and disability, and what impact does that have on individuals, and then what impact does that have on our communities, and what impact does that have on our society. And that takes a big conversation. And I'm not sure I know how to get all those people into the same room to have the conversation, but I do think that is where the conversation needs to go.
Excellent, Romy. So I'll promise that this will be my last question before we end. I know that you have touched a few times implicitly, but are there any things or any lessons that we might share or teach developed world from developing countries in terms of pain management or pain research or pain care?
What can we teach the developed world? Just get out there and do it at a primary healthcare level. It does not need complex tertiary level chronic pain teams. It needs well-informed and empowered rehab professionals and family physicians at the primary healthcare level to make a difference. And I really think that the developing world is going to show this in the next 5 to 10 years over and over again, that if we have occupational therapists and physiotherapists, nurses and family physicians at the primary healthcare level who understand pain and who are empowered to manage it, that we can make a fundamental difference.
So important point, Romy. Thank you. Thank you so much for your insightful thoughts. There are tons of takeaways, and I could have gone hours longer, but I know I have to stop. Thank you, Ben, for organizing, and thank you, Romy, for my
invitation.
invitation.
Thank you. Saurab, you can be a talk show host anytime.